Well, welcome to our next Rad Path lecture. We'll be talking about the retroperitoneum. My name is Matt Hartman from Pittsburgh, PA. I'm a member of AMSR. We have a nice gross specimen here of a perirenal tumor. We'll see what this ends up being. Again, you can find the entire lecture at the ACR building blocks site. To get the Rad Path flashcards, go to the About section for our YouTube channel to get the instructions. Again, before trying this module, make sure you have reviewed the module about renal pathology, as well as the adrenal pathology, as this will complement that very well. This comes from an RSNA presentation done several years ago about primary retroperitoneal tumors. Again, if you want to see the entire presentation, go to the building blocks, download it, take your time with it. I'm going to be showing an overview to sort of get you primed, give you some highlights, some pearls, so that will make more sense when you go through it on your own. So we'll define what a retroperitoneal tumor is, we'll categorize them, and then we'll do some unknowns and come up with differentials for each of these cases. So a primary retroperitoneal tumor arises from soft tissues around organs, the retroperitoneal organs that we know and love, such as the kidney, adrenal gland. There's no primary attachment to the retroperitoneal organ, and a retroperitoneal lymphoma is not a primary retroperitoneal tumor since it arises from a retroperitoneal organ, the lymph nodes. This is a diagnosis of exclusion. And if you remember one thing, every differential, mesenchymal. So if you're trying to come up with a differential for any of these cases, think mesenchymal and you'll probably be right. Remembering that uncommon manifestation of a common disease is more common than a rare disease. Mets and lymphoma occur commonly. You will see this much more often than a rare tumor such as a malignant fibrous histiocytoma. So some pearls. Again, we'll see these when we do our interactive cases. Always think Mets lymphoma. Number 2, a retroperitoneal tumor that invades bone is lymphoma. Number 3, if there is fat, macroscopic fat, we made a big deal about this with our adrenal talk, think liposarcoma. However, not all liposarcomas will have fat, but keep that in mind, common things will occur commonly. Number 5, if you have a retroperitoneal tumor with lots of necrosis, think leiomyosarcoma. Number 6, a malignant fibrous histiocytoma has a predilection for the perinephric space. Number 7, we get a PEDS pearl here, and a kid with a calcified retroperitoneal mass, think neuroblastoma, ganglioneuroblastoma, or ganglioneuroma. And again, remembering from our adrenal talk, if you have an elevated VMA, if you have that laboratory value, that it will really help you. Paraganglionomas will have high VMAs. Number 9, in a kid or young adult with retroperitoneal tumor and fat, think teratoma. And finally, keep this in mind. Often we're just trying to get a differential. Sometimes we cannot nail the diagnosis and come up with the exact diagnosis. Describing the location, describing the characteristics is useful for surgical planning. Again, tissue will be the issue. It is imperative that we know our retroperitoneal anatomy. You have the anterior perirenal space, which will include the pancreas and parts of the colon. You have your perirenal space, which will include the kidneys and the adrenal gland, and then the posterior perirenal space, which is more of a potential space. Okay, let's start with the unknown. 53-year-old male with left abdominal pain. Rule out diverticulitis or stone. Well, I don't see a kidney stone. In fact, I don't even see the left kidney here. Instead, I see a solid, large infiltrative mass centered in the retroperitoneum. Remember the Hartman rule, every differential, Mets and lymphoma will be right. This was metastatic testicular carcinoma. Another case, left abdominal mass. Again, solid, but areas of central necrosis. On the MRI, we see there is bony involvement. It's coming from the bone. If we remember the pearl tumor that invades bone, think lymphoma. If you just said, hey, every Hartman differential, Mets and lymphoma, you would have been right as well. So let's talk about retroperitoneal tumors and how we characterize them. Well, we have mesenchymal, neurogenic, and embryonic rest. For mesenchymal, liposarcs will be our most common. Older adults, males greater than females, females greater than males, and they will have dirty fat in them. Leiomyosarcs, much rarer, but you remember the pearl, necrosis and IVC invasion. And then malignant fibrous histiocytoma, loves the perinephric space. Very rare, but if you see a perinephric tumor, be thinking this as well as lymphoma. So what do we have here? We have a large retroperitoneal mass, and you see the low density, and measure it, negative 68 Hounsfield units. We have macroscopic fat. This is liposarcoma until proven otherwise. Note the bowel being displaced by this large process. Again, under the microscope, we get the macroscopic fat, liposarcoma. 57-year-old male with fever, night sweats, and weight loss. This case might look familiar. Perinephric solid mass. Lymphoma definitely in the differential. But if we remember the other tumor that likes the perinephric space, malignant fibrous histiocytoma, and common things being common, liposarcoma. This was a fake out. Again, these are differential cases. Tissue is the issue. And remembering that not all liposarcomas will have macroscopic fat. Here's a 53-year-old female with back pain. Another case with some low density, looks like some fat. But it's not fat. It's more water density, and you have to say, is this cystic or is this necrosis? And this is necrosis when we get the gross specimen. This was a leiomyosarcoma. Extensive necrosis. It also likes the IVC. So middle-aged female with back pain. We get a perirenal tumor, looks solid. Maybe there's some fat, maybe there's not, maybe that's engulfed fat. Again, it's going to be a differential case. That's lymphoma and malignant fibrous histiocytoma. This is a tumor that likes the perirenal space. Again, it's a differential case. No way you could nail this preoperatively. Let's switch to neurogenic tumors. We have our neural crest cells, derivatives, neuroblastoma, ganglioneuroblastomoma, ganglioneuroma, and pheochromocytoma. We have our peripheral nerve tumors, neurofibroma and schwannoma. So this is a young patient, 13 years old, with abdominal mass. And what do we have? Well, multiple retroperitoneal masses. Here's our aorta. The aorta is being lifted off. We're thinking something pretty aggressive, probably some necrosis there, some calcification. And this is a neuroblastoma. The kid with a calcified retroperitoneal mass, think neuroblastoma. This patient, we have the elevated VMA levels. That's very helpful. And we identify the retroperitoneal mass. Here's on the MRI. Here's the aorta. And this should sound similar to one of the adrenal cases from before with elevated VMAs. And this is going to be a paraganglionoma of the organ of Zuckerkandl, so sort of an extra-adrenal pheo. Remember, in the rule of tens, 10% can be extra-adrenal. Our last category, embryonic rests, we have teratomas. And remembering those will have often fat in them, will include all germ cell layers, can be mature or immature. And then something very rare, which you can read about, fetus and fetu, basically an extremely mature teratoma. So here's a 17-year-old female on the scout. You can see a calcified mass, maybe some lower density, easy to pick up here on the CT. This is our fat density, negative 63 Hounsfield units, macroscopic fat, calcium, young patient. What are we thinking? Teratoma, calcium and fat. 55-year-old male with elevated metanephrines. Again, it's very lucky we have the laboratory value. What are we seeing? multiple heterogeneously enhancing masses. They're centered in the retroperitoneum, central necrosis. This is a malignant pheochromocytoma. So in summary, a retroperitoneal tumor is a diagnosis of exclusion. Always think Mets and lymphoma. And remember our three categories: mesenchymal, neurogenic, embryonic rest.